Good morning, friends. Welcome to our next learning session. And today I'm going to talk about a girl who was brought to me about 30 years back. She had low grade fever, lot of pain abdomen, griping, and vomiting. She was just a student of 12th class, unmarried, female, like the usual school students. She had not been eating because of the pain abdomen. Considering that it is a case of gastroenteritis, I gave her injection Baralgan 5 ml intravenously and injection sequel 10 mg intramuscularly. Baralgan was the smooth muscle relaxant available at that time and very effective in cases of renal colic as well as intestinal colic, gallbladder, biliary colic. In these conditions, we used to frequently use it. I had used it during my house job and later on also, and I always have been benefited. Some other, it is now a banned drug, it is now not available. Since the patient did not get sufficient relief, I thought of consulting another senior consultant physician who was retired as a professor of medicine from a teaching institution, and nothing came out except discussing few conditions as a differential diagnosis. Then I decided to admit the patient in a nursing home and look after her dehydration. She was not eating anything because of the pain and vomiting, and therefore she was partially dehydrated. She had local tenderness in the sigmoid region as well as the ileocecal region. Her liver was not palpable and spleen was not palpable. There were no rash anywhere on the body. There was no anemia, jaundice, cyanosis, or edema. So I admitted the patient to a nursing home and started 5% DNS intravenous infusion. With fluids, the patient's dehydration diminished and patient felt better. But I consulted the surgeon, who was also a friend of mine and senior person trained at All Institute of Medical Sciences, and he was also of the opinion that this is a case of acute appendicitis. Therefore, we started making preparations for the operation. I asked him for any tests which are required to be done. He said nothing in particular except that hemogram and BTCT should be done and urine examination should be done. But I went against it. I sent the blood for all the tests which I used to get done as a part of my practice. I got liver function, kidney functions, complete hemogram, BTCT, platelet count, everything. And the pathologist rang me to tell me that if operation has not been started, please wait. Due to good luck, the operation got delayed because the surgeon got stuck up in the other hospital, and meanwhile we got all the reports of liver function. This time we knew that SDOT, SDPT is more than 2000 international units, and therefore it is a case of hepatitis. So operation was abandoned and the patient was put on complete bed rest. Next morning I requested another senior professor of medicine and hepatologist to come and see the patient. He came and he agreed with me that this is a case of viral hepatitis with some atypical features, and therefore there is no need to keep the patient in the hospital. Patient can be kept at home and patient can have complete rest at home. The high carbohydrate diet with restricted fats and proteins should be given in the beginning, and as the appetite improves, we can add the proteins and fats also. So friends, before I go further with the details or art features of the case, I want to tell you that look at this diagram. Now this diagram, you first know that what is the position of the patient. If the patient is standing up, this is the head side of the patient, this is the feet side of the patient, this is the right side of the patient, this is the left side of the patient, this is the liver, this whole is liver, this is big portion right lobe of the liver, this comparatively small wedge-shaped portion, this is the left lobe of the liver, and this above the liver, this is the heart, this is in the chest, this is in the abdomen. Look at another diagram, and what do you find? In the center, what is this? This is the liver. Okay, and just above this portion, this is the diaphragm. Okay, this is the diaphragm, and this portion is this is the sac-like structure. See this sac-like structure. This is the stomach, and this is the liver, and this portion is this portion. See closely. This portion is the transverse colon. This portion is transverse colon. Liver, transverse colon, stomach, and this is the diaphragm, and this is the other portion of the diaphragm. This is spleen, this is the left lung, this is the right lung. So in this diagram, lot of structures are shown: right lung, left lung, left diaphragm, right diaphragm, spleen, liver, stomach, and this is the transverse colon. See one more diagram to understand what I am trying to describe. Is this is the abdomen, that is the tummy, belly. This is entire thing shown is the large intestine, also called colon. You see, this is the right side, this is the head side, this is the feet side, and this is the left side. On the right side, from here the colon starts. This is the rounded area is called cecum. From there it goes up, it is going up, that is why it is ascending up, that is why it is called ascending colon. Then it goes right up and then again comes down, making across the stomach, across the abdomen, across the belly, going like this. This is called transverse colon. Then again it goes right up to the rib margin and then takes a turn to come down here. And since it is descending, like we descend from the stair, it is called descending colon. Then it goes inwards, backwards, and slightly upward. This is the sigmoid colon, and then this is the rectum, and this finally is the anal canal. So food enters from here, gets absorbed, and the unabsorbed portion comes out here as feces. Now friends, after having made the diagnosis of acute viral hepatitis, we have to discuss certain important points. One important point is that the virus of hepatitis blows away the cells of the liver, leaving behind the scaffolding of connective tissue that is just like leaving behind the outline, or like you install certain pillars or bamboos iron pipes to let the mason make the building. For going up, they have to make a scaffolding on which they climb up and make the thing. So this type of scaffolding remains in the liver, and if we give sufficient time to the liver can recover along with this scaffolding with original liver tissue. Remember it, the recovery, this is a unique feature of the liver, that recovery occurs with the original liver tissue, both structurally as well as functionally. In no other place the recovery occurs with the original tissue. If we do not give sufficient rest to the patient, then this scaffolding collapses, and the result is the cirrhosis of the liver, which I mentioned in another case of our patient. Here the patient had no jaundice, and that we know that 2 to 3% cases of hepatitis, they are without any jaundice. Still, there was no enlargement of the liver downwards, but when we got ultrasound done, we found that liver was enlarged upward. This was also an atypical feature, that liver, instead of enlarging downwards, had enlarged upwards. Spleen is enlarged in about 15% of cases. Liver is enlarged more commonly, about 50 to 60% of cases, and the skin rash occurs in about 5% of cases. But we did not have a patient, and we therefore need not to mention these features. So what was the unusual feature? Unusual feature in our case was that there was no jaundice. Unusual in our feature in our case was that pain of hepatitis occurs in the right hypochondrium, but in our case the pain was occurring in the right iliac region. The other unusual feature was the liver enlargement was upwards rather than downwards. So friends, this was the patient of acute hepatitis mimicking gastroenteritis and appendicitis, but could be separated out by certain investigations like liver functions and blood tests, and we could treat the patient well. I have followed up this patient for 30 years now. The patient is perfectly alright. There is no effect of any type, no cirrhosis or nothing. Thank you very much.